We are going to speak about stroke prophylaxis using left atrial appendage closure. And I'm very pleased to have with us David Foley and Martin Bergmann, who are real super experts in the field. So may I start with you, David, and ask you, what is the evidence we have today about LAA closure in patients who had a stroke?
So thank you for that, Alec. The evidence has been gathered over the last number of years with PROTECT AF and PREVAIL, the particularly randomized trials, which have shown the most salient point being the reduction in mortality and all-cause death after 4 years, despite some early glitches in periprocedural complications in the early phase. Then the continued access registry, CAP, and now we have EWOLUTION that Martin will mention and discuss. So there's an accumulation of substantial evidence now which indicates that there's significant risk reduction in stroke and all-cause death, and also in hemorrhage, obviously from avoiding taking anticoagulant drugs.
Okay, so gross is the picture is thousands and thousands of patients treated?
Yeah, so we've thousands and thousands of patients treated in real life, and EWOLUTION is real life, and that's what we'll use as a substantial piece of collected evidence in real life patients without any exclusions.
Okay.
Because the trials could be a little bit criticized that they were cherry picked a little bit perhaps, and that the patients were eligible for anticoagulation or closure, whereas in our real life practice we probably focus more on patients who are not great candidates for oral anticoagulation.
So thanks for setting nicely the stage for Martin. So Martin, you were one of the PIs of the EWOLUTION Registry, recently published. What does it add to our current knowledge?
Well, I think the issue with LAA closure has been that we had a gap between the development of the field and the guidelines and the studies. As just mentioned, the problem was that in the randomized trials who showed non-inferiority of the technique regarding efficacy, patients who were eligible for oral anticoagulation were included. Now logically, with the development of NOACs, we've seen that the gap that we have in stroke protection is actually the patients that have a relative or absolute contraindication to oral anticoagulation. And that's what we're doing in practice. Now the gap is, how do you deal with post-procedural drug regimens? What is actually the occurrence of gaps next to the device? And what about periprocedural risk? Because if you're doing a prophylactic intervention, obviously the higher the periprocedural risk, the lower the benefit for the patient.
So that's very interesting. And you briefly touched, both of you, about the new oral anticoagulant. What do you feel? What could be the role of the new anticoagulants and the LAA closure device? How do you see their respective roles?
Yeah, there can be a little bit of a symbiosis in it, that in EWOLUTION, while there aren't any significant differences in the antithrombotic regimens after implantation, it does look like that the NOACs used in not a huge percentage of the group, but was associated with very favorable appearing clinical outcomes, with the evidence of bleeding is quite low, and evidence of thrombus on the device is very low, and maybe even lower looking, but not significant, than dual antiplatelets, which has become part of most people's everyday practice because of the high proportion of people who can't take them. So I think the steadiness and predictability of NOAC therapy probably is considered superior to warfarin and Coumadins, and there may be something for comparative or randomized comparisons of NOACs versus LAA occlusion in due course. That may happen. For the moment, I think there is room for a little bit of overlap in our practice, where we will apply LAA closure in people who are not suitable for anticoagulation, and probably lean towards NOACs in those who are.
Martin, do you share David's views on the potential best candidate we have today for this LAA closure technique?
I think there are two issues here. One is, and I think you're referring to that, is regarding what do we do periprocedural until the device is endothelializes. And to come back to evolution, this registry now really solves the problem what you should do with these patients. You mentioned dual antiplatelet is the standard that we're using in Europe and I think throughout the world, and all those patients that have an contraindication for warfarin. But now we've seen with evolution that NOACs also might be an option and might come with a lower bleeding risk, because dual antiplatelet, as we know from PCI, has a substantial risk of bleeding, especially in these patients. You can't stop it if they start to bleed. Now with NOACs you have the 12-hour half-life and you can safely use them. But there's another issue, which is obviously what do you do in the beginning? I mean, do you transfer a patient for LAA closure, or do you go for long-term NOAC therapy? And I think we have to admit that the first choice at the moment is NOAC therapy. I mean, we've seen the data from the NOAC registries, 160,000 patients followed, highly efficacy. But what I see happening in Germany and maybe also throughout Europe is that GPs start to reduce the dose of NOAC once a patient is bleeding under NOACs. And it happens. Gastrointestinal bleeding, bladder bleeding, skin bleeding, whatever. And if you do that, it's more like you have your patient on an INR of below 2, 1.5 or something. So we're left the patients with a reduced stroke prevention. And that's where LAA closure comes into the picture, because we now know we can do this procedure in evolution with risk, if you just look at the serious adverse events that are not fully recovering, where the patient really has a long-lasting effect. It's 0.5%. So with this procedure, we are really down to the risk of a PCI or a pulmonary vein isolation now. And that's why I think we can apply it to all those patients that are not on full dose NOAC or that cannot take NOAC at all. And this is a huge step forward, because at the moment we are living in a niche. We're doing 30 to 50 patients, I think, in the big centers per year. But I see a lot of patients running around with not sufficient stroke protection.
So we have some evidence, building evidence, that's quite good. Idea about who could be the best candidates. Of course, in the guidelines, it's not fully stated. Maybe we'll see the new AFib guidelines during the summer at the EAC Congress in Rome, and let's wait. And how do you see, I come back to you, and David will probably comment on that, how you see the development of the technique of LAA closure?
Well, I think LAA closure now, coming from EuroPCR 2016, seeing the evolution data, all the educational activities that we have started here together, should be part of every structural heart program, because you have all the tools available. You have your TE guide that guides you through a mitral clip procedure, maybe also through a TAVI. You can do conscious sedation, and that's all you need actually to get involved in this field. Look at your patients, what is the stroke protection that they get, and if they are not suitable for NOAC, go forward and do an LAA closure on them.
And David, you agree with this?
I do, yeah. I think that the technique is going to evolve substantially. I think that the safety that Martin mentioned is the most important thing. The biggest step forward since the early trials that stuttered a little in showing us evidence was they were hampered by a starting complication rate of in the region of 7%. Now we're 0.5%. That's a massive difference. If you were to apply statistically that type of complication rate to the PROTECT AF, then suddenly you've got a whole different outcome. And this is the big difference, is the safety because of numbers. We build volume and proctoring. I think over the last 5 to 10 years, proctoring for chronic total occlusion, proctoring for mitral clip, proctoring for TAVR, and for Watchman and other LAA occluders has become the way forward, and helping colleagues visiting colleagues to help colleagues to get going, and them visiting big centres that are doing it. So helping each other to apply the best techniques to patients the safest way we can. And this is, I think, the honourable part of medicine in general, is that it's gone back hundreds of years, is colleagues helping other colleagues to develop new techniques and new tricks to apply technology at its best.
Okay, so I think you nicely made the point. Evidence is growing. Now our task is to build proper training and also bringing the best evidence in order to have a shining future. So thanks so much to both of you.
Thank you, Alex.
Thank you.